Okay, so this is the last of a series of a lecture or presentation on the alpha cell modules or alpha cell course. It is the novel therapeutic approach targeting the glucagon pathway, the emerging role of glucagon in the treatment of type 2 DM and other metabolic derangement. Okay, here's my outline. First, I will briefly review the role of glucagon in the pathogenesis of diabetes so that we can link it to the potential therapy. Uh, I will also discuss the therapeutic target using the glucagon signaling pathway and the very important receptor of glucagon, which is called 7-transmembrane receptor that is linked to GPCR or G protein coupled receptor. There are several therapeutic strategies, and number one is glucagon antagonist. Okay, when we through antagonist, what we want here is to eliminate the hyperglycemic effect of glucagon, since in the pathogenesis of diabetes there is an excess or inappropriately high glucagon level, and this can be done in several ways. One is by using antisense oligonucleotide or sometimes called ASO or ASO. And this is the effect is to reduce or block the expression of glucagon receptor. Number two is monoclonal antibodies. It neutralizes the circulating glucagon before it binds to the receptor. Number three is glucagon receptor antagonist, which is a small molecules that binds to the receptor and inhibit it. And in terms of glucagon agonist, the desired effect that we want is the energy, metabolism, and weight loss. But again, this should be balanced with the undesirable hyperglycemic effect, so that by levering with the gut hormone, for example, GLP-1, oxyntomodulin, and etc., other gut hormones, this would counteract the undesirable hyperglycemic effect of glucagon. Okay, so this is what I meant when I say glucagon synthesis, secretions, glucagon signaling pathway, which is the biological actions of glucagons on an individual target organs. In the synthesis, like for example in the alpha cells, there is a gene called pre-pro-glucagon genes that encodes for a very large amino acid structure called pro-glucagon structure. It's about 180 amino acid sequence that is present in the alpha cells. It can also be present in gut cells, in the brain, uh, in the islet cells, etc. Okay, but in the alpha cells, there is the PC or prohormone convertase 2 specific for the alpha cells that split the long pro glucagon genes into a 29 amino acid sequence called glucagon. In the gut, there is another pro hormone convertase, okay, enzymes that's called 1/3 that split the pro-glucagon structures into GLP-1 or GLP-2. Okay, so this is important to know since some drugs act on these specific steps. Then, as far as secretion is concerned, when glucagon is already in the alpha cell that is formed, there are a lot of hormones, nerves, neurotransmitters that can stimulate or inhibit. It's either through the process of paracrine, autocrine, or even neural, endocrine, nutrients, and even drugs. And the last one is the actions. The target target cells or organs or tissues that contains the GPCR, that's the receptor, and the signaling pathway. Okay, the target organs can be islet cells, liver, heart, adipose tissue, GI tract, kidney, brain, and even adipose tissues. There are GPCRs present there. The most important in terms of glucose homeostasis and synthesis of glucose and hyperglycemia through glucagon is in the organ or in the target organ liver. Okay, let us now review briefly the role of glucagon in the pathogenesis of diabetes and the changing dogma since the discovery of insulin. In 1922, after discovery of insulin and successfully used in the clinic, insulin was considered the major hormone and may be the only one that is involved in the pathogenesis of type 1 diabetes. Okay? But in 1975, after the discovery of glucagon effects, it has been shown that some of the catabolic effect of type 1 DM are due to glucagon excess, such as increase in hepatic glycogenolysis, gluconeogenesis, increased ketogenesis, and decreasing glycogen synthesis. This contribute to the insulin lack and the so-called bihormonal hypothesis. So at least two hormone, insulin and glucagon. And finally, in 2011, glucagon excess leads to increase in hepatic glycogenolysis as well as gluconeogenesis and ketogenesis. Animal studies inhibiting glucagon did not lead to a catabolic symptoms or syndrome and ketogenesis despite the total lack of insulin. So, from bihormonal, it became a gluconocentric view hypothesis of diabetes. Again, that is just a review. Okay. Now, in terms of type 2 diabetes, the rationale in antagonizing glucagon as a therapeutic value is because we know that in type 2 DM, there is hyperglucagonemia or excess or inappropriate glucagon secretion, and lowering glucagon level will be a valuable therapeutic target in the treatment of type 2 DM. Okay. Now, basically, uh, antagonizing the effect of glucagon either by inhibiting the secretion of glucagon and the alpha cells or inhibiting the circulating glucagon hormone through glucagon neutralizing antibodies or blocking the GPCR, the receptor for glucagon, and it's inhibiting its signaling pathway. So there are several ways on how to do it. Okay, let us now review the experimental evidence supporting the potential drug target for diabetes. This is again just a review of my first presentation. Now, number one is somatostatin, which suppresses glucagon, and we know somatostatin has the ability to inhibit the actions of glucagon, and when combined with suboptimal dose of the insulin in type 1 DM, it reduces the hypoglycemic dips and prevent the hyperglycemia from the hyperglucagonemia, thus improving the glycemic volatility in type 1 DM. I'm sure you still remember my last presentation. Okay. So number two, glucagon knockout mice in a wild type mice treated with streptozotocin or CTZ insulin devoid mice. In this knockout glucagon receptor mice did not give rise to hyperglycemia even in a total lack of insulin. Number three, glucagon neutralizing antibodies. This we did not fully discuss before, but using these monoclonal antibodies that neutralizes the circulating glucagon is one way to inhibit excess glucagon that we see in both type 1 and type 2 DM. Number 4, the peptide receptor antagonist. This is still in an early development in the pipeline, a peptide that antagonizes glucagon. However, since it's a peptide, it has to be administered parenterally. A better one are the non-peptide antagonists. That's number 5. Okay, which therefore can be taken orally. So all of these are to antagonize the metabolism of glucagon, basically to prevent the hyperglycemic effect of glucagon. Okay. Now, The following are the list of agents that is already available in the market that have been shown to possibly reduce glucagon secretion by different mechanisms. You can see on top is octreotide or the synthetic somatostatin. Okay, the mechanism of reduction of of glucagon is a direct action on the alpha cell. Okay, as well as target in the direct actions on the alpha cells. While the amylin, some articles will say it has a direct inhibition of alpha cells. Some articles says it's centrally acting. Okay, so for the GLP-1 and DPP-4, both are incretin-based drugs, and it works on a GLP-1. So it does not have a direct action on alpha cell, but it's more on a delta cell that stimulate the delta cells to secrete somatostatin, and somatostatin in turn reduces or inhibit alpha cells to reduce glucagon level. Okay. Now, the next is leptin or metrelleptin as a drug. It is already available in the state for the treatment of lipodystrophy, and you can see that the action is both directly on the alpha cell as well as centrally. Okay, insulin can inhibit alpha cells, especially in the islet intra-islet cell environment, and because insulin inhibit alpha cells, it reduces glucagon. Now, the following existing DM medication that may directly or indirectly affect glucagon secretion or action. Number one is insulin, as we already mentioned, suppresses glucagon secretion from the alpha cells, especially in the intra-islet cells. Okay, metformin, interestingly, may inhibit glucagon signaling in the hepatocytes in the liver by increasing level of AMP and thereby inhibiting the conversion of ATP to cyclic AMP by adenyl cyclase. Now, cyclic AMP is the second messenger of the glucagon signaling pathway. Okay, so we need to understand what is this GPCR, what is this glucagon signaling pathway in order for us to fully understand the effect of metformin. Now, sulfonylurea is unclear and may vary between agents. No? Pramlintide, we already discussed that. It decreases postprandial glucagon secretion from alpha cells. And the last three are the most commonly used, currently the most commonly used anti-DM drugs, the incretin-based drug we already discussed, and they decrease glucagon secretion. However, uh, on the contrary, SGLT2 may increase glucagon secretion by inhibiting the SGLT2 sodium glucose co-transporter that may be present in the alpha cells. Now, despite this is metformin, despite the wide acceptance of metformin as the first-line therapeutic for diabetes, its mechanism of action until now remain unclear. And in this side of the pathway that explain the inhibition of glucagon by metformin leading to a decrease in cyclic AMP and increase in AMP. A decrease in pKa that leads to an effect in the reduction in hepatic glycolysis as well as hepatic gluconeogenesis. So this is more of inhibiting the glucagon signaling pathway. Another article showing biguanide suppresses hepatic glucagon signaling by decreasing again the production of cyclic AMP. And again, cyclic AMP is the second messenger of the glucagon signaling pathway. The first messenger is the glucagon when glucagon attaches to the GPCR receptors that is present in the membrane of the specific target organs for glucagon. Okay. Now, this is the last um, data for metformin. Okay, this is an animal experiment to show metformin inhibit glucagon signaling pathway by decreasing cyclic AMP, which is the second messenger. On top, okay, A and B, you see that both penformin or rather penformin has shown to reduce cyclic AMP and increase in AMP on a short-term administration. You can see 2 hours. Okay, in the middle, you can see both penformin, okay, the first one, and then metformin also reduces cyclic KMP on a longer period of management, that is 24 hours. And the last panel there is the uh, the reduction of pKa is also seen, as well as the reduction of gluconeogenic enzymes. So, in other words, metformin inhibit the uh, um, glucagon signaling pathway. Okay. Now, let's go now to GLP-1 receptor agonists. So basically, there are two types based on the duration of action. There are short-acting, exemplified by exenatide, the original one, which is given twice a day, and lexisinatide. So lower mainly postprandial glucose, partly by inhibiting gastric emptying. Conversely, long-acting molecules, for example, albuglutide, dulaglutide, exenatide LAR, or long-acting release, liraglutide, all targets predominantly fasting plasma glucose through their insunotropic as well as the glucagonostatic action. The GLP-1 receptor agonists, the alpha cell do not express or show GLP-1 receptors. So the insulin synthesis and secretion in the glucose-dependent manner and glucagon level, this latter effect could be exerted through neural regulation and of course somatostatin. To better understand that, here's the cartoon. When GLP-1 is released, GLP-1 stimulate beta cell to secrete insulin. Okay. GLP-1 also stimulates somatostatin at the same time, and stimulating delta cells increases the level of somatostatin, and somatostatin inhibit alpha cell, thereby glucagon level reduces. Okay. Now, one interesting data from liraglutide is the paradoxical increase in the post-challenge glucagonemia in patients with early type 2 DM, as shown in this slide. Okay, this is a chronic therapy, and it was associated with paradoxical enhancement of post-challenge hyperglucagonemia. Well, this data does highlight the need for further understanding of the impact of chronic, long-term GLP-1 agonist therapy on the alpha cells and islets physiology. The mechanism by which chronic liraglutide treatment may induce post-challenge hyperglucagonemia remain unclear, as well as its clinical implication, so that the effect remain to be further elucidated. Now, let's now go to DPP-4 inhibitors, the other incretin-based drug. As you know, it has the same principle involved here. The effect is of the endogenous GLP-1, and because the DPP-4 inhibitors inhibit the degradation of the enzymes that degrade GLP-1. So it preserves the endogenous GLP-1. And this leads to decrease in glucagon release in a glucose-dependent manner because of the endogenous GLP-1. Okay, here's the slide showing you the DPP-4 inhibitors with the use of vildagliptin reduces glucagon compared to placebo on your left, and on your right, after a meal challenge, you also see a reduction in hepatic glucose production. Okay. Now we go now to glifloxin. Now, this is in contrast. No? SGLT2 inhibitors, sometimes called glifloxin, increases glucagon level and thereby increases endogenous glucose production. Here in these slides, inhibition of SGLT2 causes a decreased reabsorption of glucose in the renal tubules. Thus, you can see glucose is excreted in the urine with lower blood glucose level. As a net result, here using dapagliflozin versus placebo, And however, the report that type 2 DM patient treated with DAPA, glifloxin, the first available glifloxin in the market, markedly increased the glucagon level as well as their endogenous glucose production, have attracted attention to the role of SGLT2 in the alpha cells. Now, Caroline Bonner, a geneticist, and her group were the first to report and describe that SGLT2 is expressed in the alpha cells. And the SGLT2 inhibitors such as dapagliflozin trigger the release of glucagon. And more recent study published in 2019 that the SGLT2 is also expressed in a subset of human and mouse delta cells. Thus, some of the effect of the SGLT2 inhibitor in the glucagon secretion might go through this inhibition of SGLT2 on the delta cells. However, the clinical implication of this increase in glucagon secretion is still unclear. My take is the increase in glucagon level from SGLT2 inhibitor may be the reason for the predisposition of diabetic patient or people with diabetes to develop euglycemic decay for both type 1 and type 2 DM and may also contribute to the mechanism of weight loss in SGLT2 medications. Here, we see the risk and benefit of SGLT2 inhibitor medications. On your left is the benefit, okay? The benefit that we like most or desired, aside from the improved glycemia, is weight loss. However, the most that we don't like to see as an off-target or side effect is the increase in euglycemic ketoacidosis. Because if it's undiagnosed because of the euglycemia, because of the almost normal blood glucose, it is potentially fatal. Okay, so with the Food and Drug Administration hit, so the Food and Drug Administration hit Sanofi and Lexicon Pharmaceutical experimental type 1 diabetes treatment with a complete response letter. The company Sanofi hit Sanofi that developed sotagliflozin, a dual SGLT1 and 2 for type 1. Okay, the FDA concern has been raised about the risk for diabetic ketoacidosis with the use of SGLT2 inhibitor for the treatment of type 1 diabetes. So with this, the US FDA turned down the approval of all SGLT2 inhibitor for type 1 DM that includes DAPA, SOTA, a dual 1 and 2 inhibitor, as well as empagliflozin. So we go now to the drug that is in the development. First is we will discuss and exploit the antagonist. Okay, antibodies that antagonizes the circulating glucagon as well as glucagon receptor antagonists have been developed and are being assessed as possible anti-DM drugs. Several adverse effects are hampering this approach, including compensatory expansion in the alpha cell mass, alpha cells hyperplasia, okay, increased level of hepatic transaminases, and increased cholesterol level. And many of these developments have been terminated. The second one is glucagon receptor agonists, instead of antagonizing, are investigated as treatment for obesity and the metabolic syndrome. The reason is to utilize the ability of glucagon to reduce appetite and increase energy expenditure and to avoid hyperglycemia. It is combined with incretin gut hormones such as GLP-1 or the other natural occurring gut hormone like oxyntomodulin or GIP, etc. So here now, we will discuss glucagon signaling pathway together for the importance of receptors. Now, we all know as a diabetologist and very familiar with insulin receptors that are present on the cell surface of insulin-dependent target tissues and their signaling pathway. The insulin receptor is a heterodimer, as you know. The two has four subunit, two alpha and two beta cell subunit. The receptor is a thyroxine kinase receptor that autophosphorylate when activated by insulin. It autophosphorylate a lot of proteins that leads to insulin action. For example, in the liver, the insulin transduction is to store glycogen and then synthesis of fat when the glycogen storage is full. In the peripheral tissue, depending on the target tissues, insulin signaling leads to stimulation of either GLUT2 or GLUT4 depending on the tissues, and this leads to glucose metabolism. Now, it's important to understand the receptor for glucagon. Okay, it is called G protein coupled receptor. G protein coupled receptor is a very large family of human membrane receptor. It is also called 7 membrane or 7 transmembrane receptor because the protein crisscross the membrane 7 times. See, as you can see, you can count it 7 times crisscrossing the membrane. Okay, and it is linked to G protein guanine. Okay, and the guanine or the GPCR are heterotrimeric, meaning it has three subunit. The alpha the G alpha, you can see the beta and gamma. Okay, so it's a trimeric, a three subunit. Now uh, in the inactive form, it carries GDP, guanine diphosphate. Okay. Now, when glucagon attaches to the receptor, it changes the conformational chemistry of the receptors, and this leads to the G alpha change to GTP. And when this happens, the G alpha dissociate with the two subunit and become active. And when it's active, it activates the adenyl cyclase and the enzymes present in the membrane. And then this adenyl cyclase turn ATP to cyclic AMP, which is the second messenger. The first messenger is the glucagon that is attaches to the receptors, okay, and it's transduct the message to this second messenger cyclic AMP, and then cyclic AMP in turn activates PKA, and PKA phosphorylate a lot of protein that leads to breakdown of glycogen and also increase in the gene encoding enzymes, key enzymes for gluconeogenesis. Okay. Uh, Actually, there are three types of GPCR or G proteins. Okay, the G alpha S, okay, which is stimulatory. S stands for stimulatory. G alpha I, which stands for inhibitory, and GQ, it's on your left, it activates the phospholipase C instead of adenyl cyclase. It's also a stimulatory. But for glucagon, it's more on the G alpha S. Okay? So, there are a lot of ligands for these receptors. It can be hormones, neurotransmitter rather, photons, ions, vitamins, and many drugs. In fact, currently about more than 60% of the prescribed drugs works on these receptors, and either it stimulate or inhibit it. Um, it is very common. The receptors GPCR, it's more common than the insulin receptor. So, okay, so let's go to the next. Okay, so as far as glucagon receptor antagonist, in 1982, diabetic rat treated with glucagon analog possessing antagonistic effect on the glucagon receptor diminished blood glucose by 35%. Okay? So, subsequently, a range of glucagon receptor antagonists have been developed and tested in animal models. However, only a few have reached clinical trial. This may chemically be divided into three. Okay, in the three groups. Number one, small molecule GRA. Number two, monoclonal antibodies against the glucagon receptor. Number three, the antisense oligonucleotide or the ASO against the glucagon receptor messenger RNA. Okay, I've been searching for a lot of antagonists, and I came across to just one human study that reaches phase 2 trial using the glucagon receptor antibody in type 1 DM, and it is called REMD uh, 477. This is a phase 2 trial, an effect of glucagon receptor antibody in type 1, a randomized control trial phase 2. And you can see that the data here that it reduces insulin requirements versus placebo on your letter A. In the middle, letter B, it decreases average glycemia compared to placebo. And letter C, it reduces the time in hyperglycemia uh, versus placebo. And this is, they published it in January 7, 2021. They disclosed the phase 2 trial, and they are now starting with the phase 3 trial. And hopefully, there will be no uh, off-target or side effects that they will encounter. Okay. Now, this is the glucagon receptor antagonist that have potential in elevating glucagon-induced hyperglycemia in type 2 DM. Drugs that either reduce the expression of glucagon receptor. All of these appear to have glucose-lowering properties and have recently been reviewed. Although again, efficacy profile of this is promising, the side effects do not outweigh the beneficial glucose reduction. And this is the real challenge of glucagon antagonists in clinical trial. And again, just to show you, these are again some of the off-target effect of glucagon antagonists. Increase in blood pressure, increase in hepatic fat content, increased transaminase, increased LDL cholesterol, alpha cell hyperplasia, etc. Now, again, these are the summary of glucagon receptor blocking drugs that were evaluated in human, and then you can see many of them were discontinued precisely because of the side effect that I mentioned earlier. Okay, so the last part of the therapeutic approach, as glucagon receptor antagonism may result in a dyslipidemia, all the side effect, even hyperaminoacidemia and hepatic lipid deposition. It has been suggested that glucagon agonism may be a therapeutic relevance for treatment of type 2 diabetes instead of antagonizing it. Okay, targeting incretin glucagon system with a dual or triagonist to treat diabetes. The idea here is to combine glucagon agonists for the desired action on the increase in energy expenditure and weight loss, and utilize the gut hormones such as GLP-1 action to neutralize the hyperglycemic effect of glucagon. So it's the combination and the balance of the two effects. No? For the dual agonist as follows, GLP-1, they can combine GLP-1, glucagon receptor co-agonist, or GLP-1 and GIP, the two most common endogenous incretin hormones. Or maybe a better one is a multi-agonist. They say the more the better. No? They can combine GLP-1, glucagon, and GIP. Or GIP, oxyntomodulin, and PYY, which replicate or replicating the bariatric surgery, because after bariatric surgery, they found out that these gut hormones are super high, that they link this for the consistent weight loss of the patient. Okay, currently, the most effective method to improve body weight and glucose level in bariatric surgery is the bariatric surgery. Okay, they noticed that glucagon and gut hormones are elevated after surgery. Not only GLP-1 but also PYY, oxyntomodulin, and other gut hormones. No? However, bariatric surgery is restricted to patients with morbid obesity due to its perioperative risk by which the pharmacological option to treat obesity is largely desired. In this scenario, a unimolecular multiple uh, target receptors or polypharmacy, such as glucagon-based drugs, may represent a relevant alternative to surgical procedure in the treatment of metabolic diseases. Okay. Now, I included this slide. This is a superb slide to uh, look into the bariatric surgeries and weight loss. No? The proposed mechanism of weight loss in bariatric surgery, looking at the timeline mechanism in which weight loss and DM after Roux-en-Y. Okay, first you can see is the energy restriction because of the diminished gastric size that leads to decrease in liver glucose production. That's one. The next is there is a rapid nutrient passage to the small intestine because there is very small gastric area, okay, gastric surface area, leading to increase in secretion of gut hormone, okay, such as GLP-1 as I mentioned, PY1 and oxyntomodulin, okay, and this leads to increase in postprandial insulin secretion as well as decrease in postprandial glucose. And later, maybe weeks or months, this also leads to increase in satiety because you all know that GLP-1, not only GLP-1 but also PYY is also an anorexigenic peptide. It loses weight, it loses appetite, and thereby patient lose weight. And the result of this is improvement in weight loss as well as in improvement in the peripheral insulin improvement in insulin sensitivity. And all of this leads to improvement on glycemia. Okay? Now, the reason for the development of GLP-1 slash glucagon dual agonist is to explore the efficacy of combined glucagon and GLP-1 agonism in a single peptide. Number two, to minimize the hyperglycemic effect of glucagon agonism by the effect of GLP-1. And number three, to utilize the lipolytic and thermogenic properties attributed to glucagon for its weight loss effect. And in addition, the satiation-inducing effect of GLP-1 will provide strong mechanistic rationale for the development of synergistic coagonist peptide. Okay. Now, this slide will just show you, give you an idea. This is a cartoon depicts the beneficial effect of both GLP-1 and glucagon effect. GLP-1 effect in the red and glucagon effect in blue arrows. Now, depending on the site or tissues or target and their effects. Okay. This is an example of coagonist structures, an amino acid sequence of the glucagon receptor, GLP-1 receptor coagonist, a hybrid peptide of a mixed glucagon and GLP-1 sequence that was structurally supplemented to prevent proteolysis and delay metabolic clearance. How is this done? The residue derived from unique AIB. AIB stands for amino isobutyric acid to protect it from the DPP4 enzymes cleavage. In addition, there is a PEG structure or pegylated structure or polyethylene glycol to slow the renal clearance to make the structure of the drugs a longer acting. The residue derived from GLP-1 or exendin-4 are depicted in red. Residues derived from glucagon are depicted in green, and residues shared between GLP-1 and glucagon are depicted in yellow, and unique residues are depicted in orange. Okay, this is the proof of concept that the more the better. No? This is a translational superiority of glucagon receptor, GLP-1 receptor coagonist versus just one hormones or GLP-1 monoagonism. Okay? Okay. Now, looking the effect of body weight, the effect of lower dose of glucagon and GLP-1 receptor co-agonist in blue diamond, okay, versus just liraglutide and monoagonism, the red circle for weight loss. You can see the difference, 3 microgram per kilogram versus 20 microgram per kilogram. Uh, and this is uh, uh, in a diet induced obese rhesus monkey following daily subcutaneous injection at the indicated doses. Okay. At the lower panel, say B and C, the effect of meal tolerance test measuring blood glucose following a 7 days of subcutaneous injection of B liraglutide in red circle, C uh, in uh, C red in blue diamond. Okay, you can see a tenfold lower dose of glucagon receptor and GLP-1 receptor co-agonist. That's blue diamond. Okay, in a diabetic rhesus monkey. So statistically significant tenfold lower dose of combined hormone versus one hormone. And these are some of the lists of GLP-1 and glucagon receptor agonists in the development. Okay. Okay, let's go now to the twin creatine. The two most commonly endogenous incretin hormones. So GLP-1 and GIP are the pair of two incretin hormones secreted from the gut in response to ingestion of a nutrient. That's why they are called twin cretins. They both enhance insulin secretion and subsequently ameliorate postprandial glucose excretion. GIP receptor activations might ameliorate glycemia but cause body weight gain. And these are mostly in animal model. But in clinical trial, we'll see, and we will see how it will pan out in this clinical trial as it combined with GLP-1. Now, this is the secretion and physiological effect of incretin hormone, both GIP and GLP-1, in different organs and tissue. The intestinal epithelium is composed of several cell types, as you know, including enteroendocrine cells, such as the K and L cells. Remember that? Uh, the, uh, the K cells is the one responsible for the secretion of GIP, and the L cells is the GLP-1. Okay? The secretion of these hormones is triggered upon nutrient ingestion or stimulation through the G protein coupled receptor present in the cell membrane. Okay, some of the nutrients responsible for the release of this GIP and GLP are commonly glucose or other carbohydrates, lipids and amino acids, proteins, and even bile acid. Okay. After secretion, the GIP and GLP-1 exerts their function in the pancreas and extra pancreatic tissues such as the liver, adipose tissue, muscle, including bone and central nervous system. Okay. Now, what I like you to focus is the uh, different effect on glucagon. While GLP-1 reduces glucagon secretion on your right, GIP increases glucagon secretion. Okay. Now, these are some example of the twincretin in a very early development, phase 1, phase 2, and even in preclinical or animal studies. Okay. Now, let's go now to unimolecular triagonist. Okay. Triagonist, the more the better, meaning three hormones that targets the receptors. Okay. Combining GLP-1, GIP, and glucagon, or combining GLP-1, oxyntomodulin, PYY, or replicating the bariatric surgery. As I mentioned, they after the surgery, they found out these gut hormones are elevated. And they link this as the reason for the continuous weight loss of the patient. Okay. So, or better still, targeting the two incretin hormones and glucagon system with triagonist. Tatlo, no? In the treatment of DM. And the essential point are the following. Number one, there is a need for new therapeutic strategies in broader activities that any current available drugs. Number two, GLP-1, GIP, and glucagon receptor have unique tissue distribution and activity supporting their combined use to treat diabetes. The three hormones that I mentioned have similar peptide sequences, permitting the development of single-sequence multi-receptor agonists. And the last one is multi-receptor agonists may be more effective than mono-agonists for reducing body weight and improving metabolic dysfunction. Okay, this is just additional slides. The pharmacological action of glucagon like peptide or GLP-1 and GIP, and the glucagon in human and in rodent. The GLP-1 is in the blue arrow, GIP in red arrow, glucagon in the green arrow. You can note that the effect of GLP-1 on the bone marrow were not confirmed in human, just in animal studies, and that the effect of GIP on glucagon secretion were observed only when glucose levels were high. As I mentioned earlier, that GIP can increase glucagon. So finally, the slides depicts the benefit of unimolecular multi-agonists. Depending which receptors or hormones are involved, for example, GLP-1, GLP-1 glucagon co-agonist, the improvement that we expect to see is more on body weight, but also for energy expenditure, glycemic control, and cholesterol metabolism. For GLP-1 and GIP co-agonists, okay, improvement is more on glycemic control. We can also see body weight improvement or weight loss, lipolysis, and cholesterol metabolism. For GLP, GIP, and glucagon, the triagonist, the impact is more on body weight, glycemic control, and in addition, steatosis that can be a treatment for NAFLD and NASH, and also energy expenditure and lipolysis. So in summary, with the elucidation of the role of glucagon in the pathogenesis of diabetes through glucagon signaling pathway, this paved the way to studies involving glucagon agonism as well as antagonism in the therapeutic potential in the treatment of diabetes and other metabolic problems like obesity. Current advances and future directions are the development of multi-agonist unimolecular peptide for obesity and type 2 DM. Okay. Single molecule drug targeting two or more gut-derived peptide hormone receptors have shown tremendous therapeutic potential. Although some novel drugs candidates have promising preclinical data, final point is to show human potential or benefit and safety to ensure bench to bedside translation. So with that, I would like to close my presentation and thank you uh, for listening, and thank you also for the PST for giving me this opportunity to discuss the alpha cell as the role of in the role of the pathogenesis of diabetes and its potential drug therapies for treatment.